Hello everybody, my name is Madeline Wilcox. I'm here from the Speech and Language Therapy team. I'm going to be speaking to you a little bit about oropharyngeal and laryngeal dysfunction in the ICU patient today, and a little bit about the role of the speech and language therapist. There's so much of, for us anyway, that speech and language therapy can focus on, so I'm going to focus on this a little bit because this is a bit that we find most interesting. So I'm going to give you a little overview of SALT, a little bit of oropharyngeal and laryngeal dysfunction, and a little bit about assessment and rehabilitation. So I just wanted to tell you who we are. So I'm Madeline, and I've worked for 23 years now since post qualification, 3 years in Derby and 20 years in UHL. I've always worked in the acute setting, and I've also worked on the wards and between ITU, going on to specialise in ITU. And I've got extensive history of working with videography, which is the X-ray of the swallowing, and more recently, and very excitingly, I've developed working with FEES, which is fibre optic endoscopic evaluation of swallowing. Behind me, we've got Alex. Alex, do you want to say a little bit about yourself?
Yeah, I've been here for coming up to 10 years now, and I've been working in IT for about 4 years since the pandemic. Again, I really enjoy working with tracheostomies and rehabbing our patients with swallowing difficulties. I am VF trained, but I missed the FEES training because I took a year off to have a baby. And then we have our colleague Sophie, who has been with us for just over a year, and she did part of the FEES training with Madeline, and she's also fully ITU and VF trained as well. So we've all been around quite a long time.
We're quite a small service. We work across 2 hospitals. It used to be 3 when we had ITU over at the General, and we still outreach to HDU on occasion. Increasing bed numbers have given rise to some more funding, and with that we've been able to fund some more posts, so Alex and Sophie, but we're still down significantly. So the GPICs recommend 0.1 per bed for speech and language therapy. So if you with the amount of beds that we've got here, that's roughly we're about 2.4 altogether, because Sophie and Alex work part-time. So that's across 3 sites. That's Monday to Friday, about 8 till 4. So it's not a 7-day service either, or bank holiday, weekend or sickness. There's no cover for that. We work with people with communication and swallowing problems, but mainly swallowing. And it's fair to say that I really see myself as a swallowing specialist. We're going to focus on the swallowing side of things today. Too much to talk about in one session, and I know you've got something else coming up after this as well. We've got an evolving role in tracheweaning. I think I've always worked with patients with tracheostomy, but I think with the advent of FEES, more and more we're becoming involved in working with people maybe before cuff deflation, and advising about that as well with the physio team. So what does GPIC say about dysphagia in ITU? We know that intubation and tracheostomy have been associated with high risk of dysphagia and aspiration, and it's frequently silent. High prevalence of dysphagia in ITU. There's a prevalence of swallowing dysfunction after extubation of 20 to 83%. That's quite a different figure there, just vary, but we know that there is research to say that it's longer for a longer duration of intubation, and longer duration of mechanical ventilation is associated with post-extubation dysphagia, and so on. And so we can see that swallowing problems may often be undiagnosed in the intensive care population due to high rates of silent aspiration, and yet they have a greater impact in this group. A lot of the information that I'm using in this this PowerPoint is based on a PowerPoint that's been given by one of our consultant speech and language therapists called Sarah Wallace, and you may have seen her in different settings. She does a really good talk actually, which you can access on laryngeal dysfunction and rehabilitation in ITU. You'll see some clips of her later on in this PowerPoint, so I just wanted to acknowledge her work here, because she does a lot. She does 50% of her time spent doing research as well. So we have a lot to thank her for. So oropharyngeal laryngeal function, it impacts on speech, which is results in dysarthria if the speech is if the muscles of the mouth are affected, if the oropharyngeal laryngeal function is involved in swallowing, voice, and airway. And those are the things that we look at when we're doing our swallowing, voice, and communication assessment. Talk a little bit about laryngeal dysfunction. So it's been identified as a big six. What we feel laryngeal dysfunction and dysphagia. So intubation, the size, ET, cuff compression of the recurrent laryngeal nerve. So cuff inflation can compress that recurrent laryngeal nerve, have an impact on the vocal cords, can have we know that intubation can cause laryngeal injury. We know that weakness caused by disuse atrophy or sedatives or myopathy can also have an impact on swallowing and voice. Impaired cognition, we see that quite a lot in ITU, well, and generally in the acute setting, and we've got a little bit about that coming up. How cognition can affect swallowing as well. So somebody who's delirious can thinking about coordination for swallowing, and just thinking about what they need to do to be able to swallow can massively impact on the swallowing function. So, for example, having something in their mouth, not being aware of having something in their mouth, not knowing what to do with it, and then they can aspirate on that. Decreased airflow and mechanical ventilation, so having a trachea cuff inflated can cause problems with desensitization and breath swallow. Synchrony becomes impaired. People who have an inflated cuff lose sense of taste and smell. They lose pressures for vocal cord closure as well. Other comorbidities that we know that affect swallowing, which we're not specifically going to talk about today, but of course we know that neurological problems, so stroke, brain injury, seizures, Guillain-Barré, myasthenia, all of those things can impact on the swallowing. Head and neck problems. Over at the Royal, we see people who have their ENT trauma or planned surgery, which impacts in the oropharynx. Sepsis, cardiac surgeries can impact because we might see some involvement with nerves, the swelling or damage to recurrent laryngeal nerves can affect it as well. COPD can affect the coordination of the synchrony of the breath swallow apnea as well, so that can impact. And then we've got laryngopharyngeal reflux, which can cause edema and vocal cord issues for swallowing. So I found this little statement and I thought it was quite interesting. It's another speech and language therapist, and he's got a blog on cognitive dysphagia. And I think it sums up nicely what I was trying to say. And he uses the analogy of, having all the components of a car for a car to function. But if the driver's not functioning very well, then it can't make the car work. Maybe you can if you've got a head. So effects of intubation. So intubation can cause laryngeal injury, and we know that. Mucosal, vocal fold palsy, inflammation, and direct compression of nerves. So we've got some pictures of that coming up. And clinical issues would be pain, spasmodic dysphagia, decreased airway patency for a one-way valve tolerance. So we might see somebody trying to trial cuff deflation and put a speaking valve onto the tracheostomy tube, but they're not able to tolerate the one-way valve, and that might be as a result of swelling in the upper airway, which might have been caused by intubation, or it might be as a result of vocal fold inflammation or some vocal fold damage and bilateral vocal fold palsy. And risk factors for laryngeal injury can include prolonged intubation, multi-intubation, and having a difficult airway to begin with and then being tubed again. And there is some research about tube size correlating with laryngeal injury as well. So here we've got a few slides which one is showing vocal fold palsy, but it's difficult to see that when it's a still picture. You can clearly see the granuloma there, and then we've got some intubation trauma that we can see to the right hand side. So oh, that picture's not coming up very well at the back, but never mind, we know that for next time. So an inflated cuff. When we've got that inflated cuff around a tracheostomy tube, it creates a lack of sensation in the upper airway. We haven't got that airflow coming into the upper airway. Patients can't smell very well, they can't taste very well. They lose it, but if you've not got a sensation, then you don't trigger swallowing as well. So that's what results in lots of people pooling secretions above the cuff, because they lose that feeling to do that. And it might result in silent aspiration. So lots of people think about cuff inflation as preventing aspiration, but for us, if fluid or food or secretions have reached below the level of the vocal cords, which are above the cuff, then they've already been aspirated. So it might not prevent aspiration, but it might just stop the progression further down into the lungs. And we know that's why we've got subglottic suction ports to suction those secretions off. With the lack of airflow, the vocal cords don't work properly. So the vocal cords function as a primary function to protect the airway from aspiration and things going down the wrong way, and they can't function to close very well during that cuff inflation. We know there are certain things that we can look out for, which would suggest that somebody is going to be at risk of having oropharyngeal laryngeal dysfunction and swallowing problems. If somebody's awake and they've had an ET tube and they're tolerant, it's likely that they're going to have been wriggling around more with that tube in their mouth. They can cause more damage as it's moving around in the larynx. This is something that I'd be quite keen to look into as well, about the people being prone with ET tube, people who have been mobilised from a physio perspective with an ET tube, and is quite interesting. That said, I have seen patients where that's been happening, and I've expected them to have swallowing problems, and they haven't presented as such, and their voice has been fine as well. So not always the case. Trachea itself doesn't always cause swallowing problems. It used to be thought that trachea tube itself caused a laryngeal tethering and weighed the larynx down, so they couldn't achieve the elevation that we needed for swallowing. But actually, it's been shown that lots of people do manage quite successfully with the trachea tube in, and it's usually the reasons for having the trachea tube in the first place that leads to a person having dysphagia. So if somebody's been multi-intubated, and the reason, the comorbidities that go along with them being multi-intubated and leading to the trachea tube is more of the reason why they're going to have the dysphagia and dysfunction. If somebody's got excessive secretions at bedside and they've got a weak cough, and especially if they're needing a nasopharyngeal airway, that for us is a definite sign. Quite often we'll get people referred to us with the nasopharyngeal airway in, but if they've got the nasopharyngeal airway in, it means that they can't swallow the secretions and they can't cough them out either, which suggests, a huge significant dysfunction there in the larynx and pharynx. The nasopharyngeal airway itself is quite a long tube and can actually impede with the pressures for swallowing. As it passes, we need soft palate elevation and the pharyngeal wall to come in, so it can actually impede on that as well. If you know that somebody's got a bulbar dysfunction and that's clear, and they've got a dysarthria, then that's going to tell us that they're more than likely going to have problems. Now, where do we come in? So assessing oropharyngeal swallowing and laryngeal dysfunction. So what we've got is a swallowing screening tool that you may or may not be familiar. Has anybody seen the swallowing screening tool? No, okay. So I'm going to show it to you in a moment. So a few years ago, I wrote a set of guidelines. I won't go into the details of that now, but on the basis of on the back of some audit that we did, the swallowing screening tool was suggested for every patient, and we've done another push for it to be used again at bedside. It should be filled up for every patient at the start of commencing oral intake. Yeah, usually by the nurses. So can we just go on to that slide and get back? So this is a swallow screening tool, and you should find a copy of it in the drawers on the units. We used to have it in the folders, then it got taken off, and it might be going on to Nerve Centre, but not yet. So this kind of gives you it's helpful for identifying who should be referred for a formal swallow assessment, who is at risk of having dysphagia. So it doesn't really necessitate any formal training as such for the nurses to have. It's not really a swallow assessment. It's identifying who's at risk of having dysphagia and who you should refer to SALT, really. Because what we found on the audit was that about 50% of the people notes that we looked at should have been referred to SALT, and they weren't. And it wasn't the people with tracheas, it was surprisingly people with myasthenia gravis, somebody who's had a stroke, and other cases. So this just helps the nurses to refer to us, really, making sure people are referred. Doctors can refer as well, obviously, and using this tool. But what we've said here is that there are instances where you may think, looking after the patient, that okay, that patient's likely at risk of dysphagia. However, for whatever reason, I've made the decision that that patient can drink, or that patient can start eating and drinking, either until speech and language therapy gets here, or not at all. We don't need them involved, and that's your decision to make, looking after the patient. So you can document there why you feel that is, and that'll be really good for us when we come to audit, because it helps us to identify where we needed, really, and why that patient wasn't seen. So any patient that comes to us to do a bedside swallow assessment, and for many years we've done our clinical swallow examination at bedside, so we're trained at length to assess oropharyngeal stage swallowing problems. But for many years, there's been a tool available called FEES, which we haven't had, but we've recently got. So it's very exciting for us. For many years, I've been trying to get this. I'm going to talk about that now. And it's really gold standard tool for assessing swallowing, and especially on ITU, it's great. It really gives some good clinical information about managing these patients. From that, we might be able to start people on oral intake from bedside. We might have enough information. We might need to refer them on for a FEES or a video philosophy, which is an X-ray of their swallowing, or make suggestions to refer on to other agencies. So we can be involved in the whole journey, and now we can be, there's a reason why we can be involved before cuff deflation trials, so you don't have to wait until that cuff comes down before referring to us, because we feel there's actually more that we could be doing. We could be helping you and the physios think about suitability for cuff deflation based on a case history, looking at secretion management, using FEES to look at that as well, thinking about cuff deflation. And then when we're getting the cuff down, we've got those tools to be able to think about troubleshooting any issues of why they can't get voice, why they can't get airflow past that tube. Can we do something with their voice, having them with their swallowing, and techniques that we can use to try and get that happening. Looking at something called above cuff vocalization, I don't know if you've heard of above cuff vocalization. No. So that's where I'll show you a clip of that in a minute. So airflow goes in via the subglottic port, and it helps people, in theory, who can't get that cuff down to get a voice, or to resensitize the larynx, and it helps with voice and swallowing. And feeds. We can also, for people who can't get their cuffs down, we can do a feeds with their trachea cuff up as well. So that, I should say, that's quite important, because there are some people who take a backward step. We've got somebody on the unit at the moment who wanted to do that with, and previously we've had somebody on the unit at the Royal, and she managed to do a fees with the cuff down. She was managing the cuff down, but we knew she was going to be long-term ventilator dependent. So we wanted to get an image of her with the swallowing with the cuff up as well. So we knew that if she needed to have the cuff back up, she was fine to swallow. Okay, so I'm going to show you this video of fees, and fees is fibre optic endoscopic evaluation of swallowing.
So we're going to use this. Swallowing problems or dysphagia is really common in tracheostomised patients, and quite often there are lots of reasons why patients have swallowing problems, and they can be quite complex. So having an early swallowing assessment from speech and language therapist is so vital, because consequences of not picking up swallowing problems leads to worse outcomes for patients and often prolonged length of stay. What we're trying to work out is why they have a swallowing problem. If we can work out why, we can work out what to do to fix it. The best and most accurate assessment tool is FEES. FEES is fibre optic endoscopic examination of swallowing. This involves a speech and language therapist passing a nasendoscope along the nose to the back of the pharynx in order to look at the larynx, look at the vocal cords, look at secretions, and look at the swallow. It's also really, really helpful for the whole MDT management of the wean. And if we pick up intubation trauma and edema and vocal cord palsies, this can actually affect what we do in terms of weaning and decannulation. We can actually give the patient food and drink with the scope in and see how at risk they are of aspiration. When we don't know if silent aspiration is occurring, what people tend to be is a little bit more cautious and keep patients nil by mouth. So if we've got much more accurate assessment, we tend to progress people onto oral feeding, even if it's only a few sips of something. If we're able to get people eating and drinking sooner, then generally speaking, they get out of hospital quicker.
Thank you, Sarah. So benefits of fees, just outlined by Sarah. It helps us to form a diagnosis, get people started on oral intake recommendations. We can have a look at upper airway collapse and edema, and we've got some nice slides coming up of that as well. We can look at vocal cord movement, although I should say at this stage we can't actually formally diagnose any structural abnormality in the larynx. So we've got a good idea of what's going on, but we have to actually have that formally diagnosed by ENT. But they can access our images. We can liaise with them. Gives us a good idea of what we need to do for treatment and in-depth analysis of swallowing. So I'm going to show you, we've got some clips here. The top image, I think it's distorted the picture, apologies, because it's on big screen. The top image was actually a normal swallow. The second one is a patient that we did on the unit a few weeks ago up here at Glenfield. And I don't know if you can make out that. Do you know what's going on there? Can you see anybody? No, yes, that's right. So we've got, where Alex is kindly lifting the little thing there, the pointer. So that's the epiglottis. Inside there, we've got swollen arytenoids. Inside that, we've got the entrance of the airway. You can see the vocal cords. this person's actually had a drink of milk. So as they're trying to drink the milk, they can't actually squeeze that. When we do a fees, we get what's called whiteout. So during the actual procedure, the screen goes white. If you had a normal swallow, you'd have a lovely, nice white screen. And that
Like
means
that.
like that one at the top. And it means you don't see what's happening during the swallow. You see before and after the swallow. This never happens on the bottom picture, but because he's not got enough pharyngeal strength. It's just not working. He's not got the laryngeal lift. He's not got the aryepiglottic folds aren't coming over the top of the airway. The epiglottis isn't deflecting. We can see milk all around the base of the tongue, the moleculae, lateral channels. You can see the NG tube, and most of it's just hanging around there. And he's actually aspirating, and it's going down into. You can actually see it going down into his trachea. So this is the patient at bedside that
We were going to start him.
somebody would start him at bedside and say start him swallowing, and that would happen routinely.
Well, he didn't feel this at all.
Yes, that's the other thing to say. So he's got absolutely no sensation of this happening, no sensation at all. So this is that was a non-tracheostomized patient as well. So that was just some. He had the trachea. Sorry, the top ones are non-trachea. Now this isn't one of our patients, but it's just another time. I just wanted to show you what a video fluoroscopy is, because we've been doing this for many years as well. It's difficult to take somebody off the unit. They have to go down into X-ray, so we've got the ability to do that here in interventional radiology. It's not too far here, but at the Royal it's quite far. And there's certain things that they need to be able to do in order to get into X-ray. It's quite complicated because you have to squeeze them between equipment. They've got to come down the ventilator generally. It's real logistical nightmare. But I just want to show you this. So what we do is we give somebody gastromyro, and we give it in certain amounts at in different amounts depending on what we think the patient can manage.
That's all right. I'm trying to slow it down.
And we might mix it with food and drink, but what's happening here is the patient in the first shot, as it says, has not got a PMV on. And in the second shot, he or she has got a PMV on. He's too quick.
Yeah, we'll show the later one. We've got more videos.
But it gives you an idea of what's going on, and with the video swallow, and it really lets us look inside the mouth, the throat, and a little bit further down as well. And we've got all different stages of parameters which we can mark and compare with for future reference. It gives us a different type of information to the fees, and both are very, very useful but different. So very similar, as I said, but different. We can see airway closures during the swallowing. So on the fees, you can't see that airway closing if they've got a good swallow. Generally, our patients, we do the fees on can't do that. But so it helps us to see how much and how much they are actually aspirating. So if somebody is aspirating, how much are they aspirating? Is it significant? What can they do once it gets down and tracks down? We can do certain swallow procedures with them that we can't do in fees to see if that's beneficial for them, to see if they can do some strategies to stop that fluid. So for example, if the fluid goes down to the level of the vocal cords and below the vocal cords, can they do a technique to stop it going any further? Can they, when it goes in, can they hold their breath and can they eject it out? Is that a technique that they could use? It's not something that we do with an ITU patient, but for some of our patients we see in other circumstances, that might be a technique that we could do in video fluoroscopy. So in our rehab then, we like to restore airflow by doing cuff deflation trials, PMV trials, doing the above cuff vocalization, thinking about tube size selection to see how that might help with the voice and the swallowing. We might be thinking about swallow strengthening exercises. We've got some basic swallow tools, and we've got a little pressure device, it's called IOP, and it's a little ball. We we've only just got that recently as well. That goes into the mouth and it can measure tongue strength, and it can also be used for biofeedback, giving people feedback to see how well they're pressing and improving their strength. So they can see that as well. Sometimes you might see patients and get them to move their tongue around and it doesn't look that bad, but then you measure it and we've got baselines, and it's actually quite weak, and the oral function can really impact on the overall swallow as well. So that's good, and we know that most of our patients are quite weak, so that's a really good tool that we can start using with them. We might actually come along and just do some oral stimulation trials where we know they're at high risk of aspiration, but sometimes the only way we get somebody swallowing is by swallowing, but we like to do that in really conditioned amounts. And then the next big thing is something called pharyngeal electrical stimulation, which is what's been talked about at the conference just this week, actually. So I'll talk to you a little bit about that in a minute. Medications can be really helpful, so we might be not directly for the swallow itself, but you know, helping. So secretion management medications, thinking about reflux medications, and sometimes dexamethasone for swelling. We might then reassess and go back and repeat feeds, do a VF, do it. Just sometimes we just need to do a repeat bedside swallow examination, a clinical swallow examination. And then obviously we're joining the MDT planning, referring on to other specialists, thinking about PEG, etc. So I've just talked a little bit about IAP. So the first picture, you can see a little tongue bulb in the mouth there. The tongue's pressing that bulb, helping increase the strength. Above cuff vocalization is the subglottic port above the cuff. We've got a video coming up on that. Pharyngeal electrical stimulation for Genesis is a brand name. I'm going to talk a little bit about that. And then EMST, which we don't do here yet, expiratory muscle strength training as well. So talking about the muscle strength and breathing out, and how that's really helping with the pharyngeal muscles as well. So this is above cuff vocalization.
We're going to try this technique called ACV, which is above cuff vocalization, and it's a way that we can help you to speak using your voice, even though this balloon on your tracheostomy tube, the cuff, is up. I'm just going to check there's no secretions there before we start. Nothing at all.
So we're just going to attach this
Just onto this oxygen here, and hopefully we'll get your voice. Louise is going to attach this, and what it's going to do, Tammy, is blow a little bit of air above the tracheostomy through your vocal cords.
just going to start turning the oxygen on now, Tammy. Okay, I'll gently be putting my thumb over this and you'll start to feel the air flow. So I'll do it nice and slowly.
So we go to a maximum of only 5 litres of air, so we want a gentle airflow. Okay. Tommy, can you try and count for me?
1, 2, 3, 4, 5.
Okay.
I have to say that you have to really cherry pick the patients for this. And I think it's dependent on different centres as well, and what kind of client group you've got. So for the people that I've tried it with, well, for a start, I haven't really found that many people that I think that it would be effective for, and for the people that we have tried it with, it's not effective. I think maybe 1 or 2 people I can think of where they presented like that lady on there. I mean, if you think you're going to stick a tube on them and they're going to talk like that, it won't happen. Well, it might do, in which case it's great. But you know, my experience is that it's not always as good as that. So, but it's something that we can use, and I think going forward in the future, we can think about that of incorporating that more, maybe in resensitization, but it's still in its infancy. There's still not enough research to say about the dry oxygen going through the tube, how much you can give to get that voice as well, the long-term effects. And for us, the aim of the game is really to get that cuff down and PMV on, really, rather than, you know, limiting yourself to that. For Genesis then, I think this is the future. I think going forward, there's been a lot of talk about this, especially in the last year. It came to my attention again over the last few months with a patient that we had over at the Royal. I tried to engage service manager about getting this for one of our patients. It's pharyngeal electrical stimulation, which is intended to improve severe dysphagia. And I'm sure we can all think of patients that we've had where they just can't swallow at all. They for whatever reason, we just can't get their pharyngeal swallow. It's like there's nothing there. And really, this is for those patients. And a catheter, like an NG tube, is passed through the nose via the pharynx, and it's got cathodes which deliver electrical stimulation into the brain. And it's 10 minutes for over 6 days, and it's showing some really good clinical results. Now, there's loads of information out there on this. You'll find loads of information on YouTube. It's something that we're going to be really thinking about over the next few months. There's some good evidence with trachea patients, ITU, stroke, yeah, and they've seen some really positive results with it. So I think, yeah, watch this space for that. And that brings me on to a patient that we had actually where I wanted to use Phygenics, and I thought about it because up until last year, it was really very much still, you could only use it if it was alongside research that you were doing. But I think it's now out for use, so that's why I approached Genesis about it as well and looked a bit more into it. But I wanted to use it with somebody that we had, a young chap in his mid-30s with Guillain-Barré, who presented to the Royal. And I'm sure some of you will know who I'm talking about. He had severe pharyngeal dysphagia. And orally he was quite weak as well, but he had pretty much what we would describe as an absent swallow reflex. He just couldn't trigger anything at all, trachea vent. We did a fees on him. Well, first of all, we looked at getting his cuff down and getting a valve on, and somebody tried him with a valve, but he kept blowing the valve off. And when we did the fees, what we could see was that if you look on the picture on the left hand side, so this is on this picture on the left hand side is as it goes in, and just over the epiglottis, just a tiny little hole for an airway. That's his airway. So if you think back to the clip we saw of the chap who was just aspirating, you could see his arytenoid, you could see his vocal cords. He's got a tiny little hole, and that's his airway, and that's why he couldn't tolerate the one-way valve, because as soon as that went on, he couldn't really breathe out. He had tiny, like, couldn't get any air out, so he would blow that valve off. And you can see it's got lots of secretions. One of the recommendations after I showed this to the consultant that was on that day, and we discussed dexamethasone, and he started dexamethasone, which is in the next picture. But actually, sorry, thanks, Alex. I meant to say that actually the first picture was when he had the cuff inflated, and the second picture is when we've taken the cuff down as well. And not the best picture.
This is the after that.
You can see both reports a bit more now. The swelling's going down, airway's opening up.
Milk.
And then we take the milk as well. And you can see that milk pouring in over the epiglottis, going into his airway.
And it's not responding.
And it's not responding, it's not swallowing. You can see some movement. The pictures are clearer on my on my equipment. It's a bit difficult when it's small because it's a bit enlarged here, sorry. Now, we did some treatment with him at bedside. Because he got such an absence, but one of the best ways to swallow is to swallow and to do things when somebody's got something there to begin with. In his case, he had very little to work with, and you're really stuck with what you can do. I did try something called thermal tactile stimulation, but again, we were limited on that. It's a really old-fashioned way of treating somebody with a laryngeal mirror. We don't have it. I couldn't procure a laryngeal mirror in the hospital because the ENT don't use them anymore. And you dip it into ice. We're not allowed ice for health and safety purposes. And you have to do it to the back of the throat. But we did some things with him. We also did IOP to work on his tongue. Eventually, we started getting some things going. He transferred to another unit, and they carried on doing something. And then eventually, we did a video fluoroscopy. So we'll show you this now. So this is some time later, and it's not great, but what we can see in the first clip and the second clip. So the first clip is fluids, and the second clip is food. He has both of those, and none of it is going into the airway. So this would be the airway here. This is the food pipe here, and he's not getting full closure. So you would normally see that would completely come together, close up, and the epiglottis would go over. But that's not actually happening. But still, he's getting a much better movement than he did when we did the fees, and we're not getting it going down into his airway. He was started on trials tentatively following this, and he went on to manage, and he went on to manage more. And they did a repeat VF, I think, and he improved. So it was a success story, and I think he improved generally, and so that was good. So in summary, that was just a little bit of what we do and a little bit of what we can offer, and I'm very excited that we've got all our new equipment here. I have got some equipment here I can show you if anybody's interested. So we can predict pharyngeal and laryngeal dysfunction, who's going to be at risk, and then we can go on to assess them in more depth. The speech and language therapy team have a significant part to play in that, I feel, alongside the MDT. FEES is a gold standard tool, and yes, we now have this available in the UHL, and I'd like to start incorporating that more. And there are new advancements in pharyngeal dysphagia rehabilitation. Watch this space. Any questions?
Thank you so much for the presentation. Really good one. To be a member of the team.
Oh, thank you. Thank you.
I'm just curious about something which I think you may have mentioned in here. I've seen in some other trusts is something called an alpha stim machine. Have you ever heard of it? It's like I think it's a neuroendocrine, not neuroendocrine, neuromuscular junction. It provides some electrical stimulus. Predominantly, it's been used for anxiety, insomnia, and things like that. But I've used an application in one trust where they use the same, I think somewhat like PES, but they use the electrodes in the pharyngeal muscle.
Oh, so what was the name of it again?
So it's called alpha stim. STIM. I think it's just
VitaStim.
Yeah.
It's VitaStim. So this is on the surface. So this is SEMG. So it's surface on the surface, and that's it's showing nowhere near to be as effective. So it's just working the outside,
Yeah, exactly.
whereas this is like direct inside to the following the pathways, where this is just more stimulation of the muscles on the surface with the kind of secondary attempt at working the brain. Is that how you? Yeah, and I was never doing that in
I think that's sort of a very apprehensive for the whole approach.
Yeah.
Like this benefits.
It's kind of like just knocks that out of the water, I think. Yeah, because it's like direct. Yeah.
Thank you.
So yeah, I'm one of the anesthetic trainees, and I'm currently doing my ICU here at the Glenfield, and I will be presenting today for the Zenon Club. So basically, the paper that we're going to be going over today was published in the Lancet in January 2024, and is about the use of ceftriaxone to prevent early VAP in patients with acute brain injury. And it was a multi-center, randomized, double-blind, placebo-controlled trial, and it was assessor must. So what was the clinical question? So the clinical question was essentially in patients with severe brain injury who require mechanical ventilation, is the use of a single dose of ceftriaxone compared with the placebo, does it reduce the incidence of early VAP? And just to give you a little bit about the background for this trial. So basically, we all know VAP is quite common in critically unwell patients and is associated with increased antibiotic prescription and poorer outcomes as prolonged duration of mechanical ventilation and increased mortality. Why did they do this in brain injury? Basically, because we know that in acute brain injury, there is an increased likelihood of VAP occurring because there is increased likelihood of aspiration prior to intubation. There have been some studies that basically they assessed the selective digestive tract decontamination that had some favorable outcomes, but there is no wide, very sort of like broadly used. And I haven't seen it, at least in the intensive care units that I've worked in the UK. So the hypothesis was that if we use a single prophylactic dose of ceftriaxone in the brain injury patients, it may actually reduce the incidence of VAP. And paradoxically, because it will reduce the total amount of days that someone will need antibiotics for, it will reduce the risk of antibiotic resistance. So the design of the study, as I said, it was multi-center, it was randomized, double-blinded, placebo-controlled. It was conducted in 9 ICU units in France. The patients were randomized one-to-one by a web-based randomization system. And then sort of like both the patients, the healthcare providers, the assessors, and the study statistician were all masked to the allocation groups. The sample size was based on the mean incidence of VAP, which they've calculated around 30%. And the hypothesis that it could be reduced with the use of ceftriaxone by half in the intervention group. And they calculated roughly that they needed a sample of around 354 patients to have a power of around 90%. And it was an intention to treat analysis. So the setting, as we said, was 345 patients they recruited. It was conducted between October 2015 and May 2020. And 171 of the patients received ceftriaxone, whilst 174 just had a placebo. 15 patients did not receive the allocated intervention, and 11 patients withdrew their consent. So finally, 300 and roughly 20 patients were included in the analysis. 162 were assigned to the ceftriaxone arm and 157 to the placebo arm. So to discuss a little bit more about the population of the study. So brain injury, they specifically recruited patients that had either head trauma, stroke, or subarachnoid hemorrhage. So they wanted to include both traumatic and non-traumatic brain injuries. They were all aged above 18 and DCS had to be below 12. And they had to be intubated for less than 12 hours to be recruited. And they had to have an expected duration of ventilation for more than 48 hours. There were some exclusions, so the ED tubes that they used didn't have a subglottic secretion drainage port. They sort of like reduced DCS, shouldn't be due to a tumor infection, disease, or cardiac arrest. They shouldn't have any hospitalization within the last month, no allergies to beta-lactams, and they shouldn't be on antibiotics on the age of the admission. I'm not going to go into the details about the baseline demographics, but as you can see briefly, they were very well matched between the two groups, both like age, BMI, medical history, they're very similar. So sort of like what brain injuries did they see? So they had a few strokes, ischemic or hemorrhagic, a few subarachnoid hemorrhages and brain trauma. DCS, the majority were between 4 to 8, 60% to 65. So again, the DCS distribution was fairly equal between the two groups. And they received the standard mouth care with chlorhexidine in both groups. So what was the intervention? So the intervention was a single administration of 2 grams of ceftriaxone, and the placebo was essentially just given some saline. And the way that they did it is they had opaque syringes that were prepared by some nurses in a nearby ward. So they weren't the nurses working within the unit, just to preserve that sort of like for the trial to be blinded. The standard measures for VAP prevention were still adhered to. So the standards sort of like ITU here of hand washing, 30-degree head elevation, monitoring the calf pressures, the markers, and using ulcer prevention. None of the centers did the digestive tract decontamination. And the criteria to actually diagnose VAP, they went with the American Thoracic Society criteria. So they had to fulfill all three categories. So they had to have clinical, radiological, and microbiological evidence to diagnose someone with a VAP. And the way that they did it is they had a committee. There were two senior intensivists that they reviewed every case. And if they had a disagreement amongst themselves, then a third intensivist would also have a look to sort of like decide whether it was a VAP or not. And then those that developed VAP received antibiotics according to the local guidelines. The outcome. So first, to speak about the primary outcome. So they did actually show that the incidence of early VAP, so they early VAP they meant by developing from the second until the 7th day, was significantly reduced in the ceftriaxone group. So it was only 14% in comparison to 32%. And the confidence interval was, to my understanding, if it does include the one, means from the little statistics I understand, it means that actually significant. Secondary endpoints, sort of like overall VAP, that means early and late VAP, was reduced in the intervention group, as also was like the ventilation-free days, antibiotic-free days, and they had a much better mortality. So the mortality in the intervention group was only 15% versus 25% in the non-intervention group. And those graphs here, basically, the incidence of VAP, either early VAP or late VAP, the patients that had been given ceftriaxone, those in comparison to those that had been given the placebo. And you can clearly see that there was a difference both in the early and the late VAP incidence. And they also looked at safety outcomes. So were there any adverse events that happened because they gave another medication to the group of patients? There were 90 serious adverse events, but none of them were contributed to the trial itself. They were felt to be due to the initial disease. 3 patients developed C. diff, but actually only one was in the ceftriaxone group. And there was 1 MRSA and 1 ESBL strain, and both of those were in the placebo group, actually. So just to discuss a little bit about the strengths and the limitations of the trial. So the strengths, it was a multi-center randomized control trial. It was blinded, and sort of like there was an independent verification for the VAP diagnosis. There was 2 sort of like physicians that were not directly involved with the care of the patient. And there was central randomization with variable blocks that ensured there was no allocation concealment. The baseline demographics were very well matched between the groups, and the choice of ceftriaxone as the prophylactic antibiotic was fairly reasonable, given its antibiotic cover and its long half-life, and also it's fairly cheap, if I'm not wrong. There are a few limitations, though, that we have to think about. I think the most important one is for VAP detection, one of the criteria that they had was the microbiological evidence. And actually, so like as a comment in the paper, they've said that the majority of cases that they didn't diagnose with VAP was because it was lacking either the microbiological aspect or the radiological, sort of like any infiltrates on the exterior, new development of consolidation. So it could possibly be, but because they've had antibiotics already, that it made it difficult to have a positive microbiology, which may have then been more difficult to actually fulfill the criteria to diagnose VAP in that arm. The trial was only actually powered for the primary outcomes. So even though the secondary outcomes seemed quite promising, the trial did not have the power for those outcomes. And actually, the 10% difference in mortality seems like it's quite a significant difference to be purely due to the 1 single dose of ceftriaxone. It could possibly be because if someone developed a chest infection, I suspect it could possibly alter how aggressively you will treat someone that had a brain injury and a VAP, but they didn't make a comment on that on the paper, at least. the committee that reviewed the cases, there were two intensivists, but they were not independent, as in they were working within those hospitals and they were aware that the trial was happening. So all the information that they were getting and when they were reviewing the cases, everything was anonymized. So the conclusion that the author made is that essentially in patients with brain injury who require ICU admission and mechanical ventilation, they actually found that early administration of a single dose of ceftriaxone can actually decrease the risk of VAP and exposure to ventilation or prolonged courses of antibiotics and prolonged ICU and hospital stay, and could possibly improve mortality with no safety concerns, which again, I think is overall, in my opinion, is a very hopeful study, but always it has been a bit of a controversial topic as to whether giving antibiotics for potential aspiration early is good or bad. But it's my understanding there's one of the few trials that actually has shown significant benefit that is out there, and it was very well designed. That's it, really. Any questions or comments?
That the ceftriaxone itself is not treating that.
Yeah, it was more to prevent it.
I was just wondering, in the baseline characteristics slides, did they take into consideration patients with, in general, health, age, like ASA grade?
Yeah, so if you see, I didn't discuss too much about it, but if you see, ages were similar, sex was similar, BMI and the medical backgrounds, like they had any significant chronic diseases. I didn't put all of them there, but they were fairly well matched, the two groups.
Any particular reason why only the brain injury patients were selected as a cohort in this study?
Because of the higher likelihood of aspiration and therefore the higher likelihood of them developing VAP. So it ties very well with your presentation that patients with brain injury very frequently aspirate and very frequently have to be ventilated for a prolonged period of time, and VAP is a very common complication for prolonged ventilation. So that's why they targeted this particular group.
But prolonged ventilation never really came up because they already capped the number of days in which they.
No, so basically all of them needed to be ventilated for more than 48 hours, and the long VAP was up to 28 days.
So they monitored the patient up to 28 days?
Yeah. So there were patients that were ventilated for almost a month. That's it. I don't know whether anyone from the Royal has any comments or questions.
We do see these patients quite a lot at the Royal. Do you think we should change our practice then, Tini?
I think personally, because they didn't demonstrate that any harm came from it, and they didn't actually find that it increases antibiotic resistance. I think it's quite promising, and if there is a chance that it actually benefits them, I think it would be sensible to do it. That's my opinion, at least.
Fair enough. We can talk about it at a consultant meeting or something. Thank you, everybody.
Thank you.